Good afternoon, everyone. Welcome to the Iron Deficiency Day. Today, we are having experts coming from all over Southeast Asia and India joining us from 10 physical locations, 3 healthcare professional platforms. We are really honored to have you here today. I'm Jess from Procter & Gamble. It's really my great pleasure today to actually introduce our Senior Director, Dr. Ashley Barlow, to come on stage to share a few words on the great work that we have done throughout Asia and also Middle East and Africa. Thank you so much for your kind attention and also collaboration in all the efforts that we have done so far. So without further ado, I shall hand over the floor to Dr. Ashley Barlow. Over to you, Ashley.
Thanks, Jess. Working? Yep. Okay. Well, good afternoon, everyone. I know I'm distracting you from your lunches. Please come to the tables, bring your food with you. We've got a great agenda this afternoon. So firstly, on behalf of Procter & Gamble Health, I really just wanted to welcome all of you here in India, in Bangalore. Thank you for joining today, but also from all around the region. So as far from field, people in Singapore, Malaysia, the Philippines, Indonesia, all joining us today to listen to our scientific agenda. The first thing I really wanted to do was to thank all of you, on behalf of P&G, for the tireless work that all of you have done over the last 2 years as we lived through the pandemic. I think that the contributions that the healthcare professional community made, treating and caring for people, very often at personal cost to themselves, is just incredible, and you really held the world together. I was reflecting recently, and there was probably one positive thing that I felt that came out of the pandemic, and that was the fact that the more that we understand the etiology, the more that we understand the pathophysiology, the more that we understand how to manage patients with conditions, and particularly share that information with the healthcare professionals across the world, then the better the outcomes for those patients suffering from that condition. And I think the way that the world responded to the pandemic, the amount of research that was conducted, and then how quickly that was disseminated across the world was pivotal, and saved many, many, many lives. So if I reflect now in terms of the role that education plays, for us, this is really important at Procter & Gamble. And that's why we sponsor and we hold these types of events, is to really provide a platform for education and for learning. Understanding the needs of patients and understanding the needs of the healthcare professionals that look after them is core to our DNA at Procter & Gamble. We believe that this is our competitive advantage. We believe that this is what stands us apart from all the other pharmaceutical companies, is that we take more time to understand what it means to have iron deficiency anemia, what it means to have peripheral neuropathy, and then how best to manage those, and what that means for the doctor. What are the best tools that we can provide to allow doctors to diagnose early, to intervene early, and to manage their patients most successfully for the right outcomes. So can I ask for the video to be played, please? Okay, apologies for that. We'll seem to have some technical difficulties. We'll play the video later. So today is really recognizing the occasion of Iron Deficiency Day. we're trying to ensure that when we hold these types of events, we create as much scalability as possible. And we bring together experts from across the region internationally and locally here within India to share with you their expertise, their clinical insights, that hopefully then you'll be able to take that information away and care better for your patients. So today's particular event, we're expecting more than 3,000 people joining, both here in India, both physically in the room, and we have other satellite centers, I think 5 satellite centers across India that will be dialing in. And then we have more than 10 other countries that are also joining to listen to the lectures and to the information that's going to be shared today. We also then push this out through 3 different educational platforms, again, across the region, to ensure that we're giving maximum accessibility to the information. And that's brought you through the P&G Health Academy, and through MediSage, through Docquity, you know, and through Allo Doctor across the region. I want to make sure that I really acknowledge and give thanks to all of the different associations that we're partnering with today, and particularly here in India, both nationally with FOGSI and regionally and locally here with the Maharashtra OBGYN Association. The effect and the impact of these events would not be possible without the partnerships of all of these fantastic associations. So thank you so much for your support, and we look forward to continuing to work with you later. Next slide, please. So just a few housekeeping rules, please, because obviously we're beaming this live to thousands of people. Please do, if you're joining online, please do stay. If you're joining via Zoom, please do make sure you're on mute at all times, to ensure that we can't get any background interference from sounds coming from outside of the room. Also, if you do have questions that you would like to ask of our speakers today, please use the chat box during the presentation. For those of you here in the room, if you have questions, then please just do seek a microphone from one of our attendees, and they'll come to you, and then you'll be able to ask your question. So next slide, please. So with that, and before I introduce our chairperson for today, I just want to offer again a sincere vote of thanks to our speakers, both here in the room and all those that we've got around the country and internationally. Thank you for giving us your time, and thank you for sharing your expert insights with us. So it gives me great pleasure to introduce our chairperson today, and I'm sure that she is a lady who needs no introduction to all of you in the room. Dr. Rishma Pai, who's an honorary consultant gynecologist at the Lalavati University Hospital in Mumbai. But I think most of you will probably know her as the ex-president of the Obstetrics and Gynecologists Association. She is an expert in the field of IVF. And has pioneered a lot of the research that's gone on in this area, particularly here in India. In 2021, Dr. Pai's work, and particularly the role that she played during the pandemic, was recognized with an Essential Heroes Award. She has organized herself more than 30 conferences and participated in more than 250 workshops, either as the organizing chairperson or as an expert speaker, conducting training for gynecologists, both here in India and internationally. So it gives my great pleasure to hand over to Dr. Pai today, who will be your chairperson. Thank you very much.
Thank you. Thank you so much. And wishing all of you a wonderful day. It gives me great pleasure to be here today for this extremely important meeting. Let me begin by saying that time and health are 2 precious assets that we don't recognize and appreciate until they have been depleted. And so, in order to create awareness about this very serious health consequence which is posed by iron deficiency, we are here today on World Iron Deficiency Day, focusing on this very, very important subject. As you know, in our region, in South and Southeast Asia, 47% of non-pregnant women are anemic, often due to nutritional deficiencies or due to heavy menses. In pregnancy, obviously, due to the increased demands, the hemoglobin levels really drop. also the blood loss during the delivery. And then as they grow older in the perimenopausal age group, a lot of them have problems such as fibroids or adenomyosis, etc., which cause them to bleed heavily and push them into the anemia zone. 52% of pregnant women, as a result, suffer from anemia in our region. Knowing the maximum benefit which can be picked up or which can be given to our patients by early determination and detection, and how we can save them from the many, many consequences of iron deficiency anemia. We have today a wonderful set of experts from across the region, different specialities, giving you their experience, sharing their experience, and of course, taking inputs from all of you. So let me begin by introducing you to our first speaker of the day, Dr. Irene. So may I have Dr. Irene's resume? Yes. So today we are going to have our first speaker as Dr. Irene Castillo. She is a hematologist, which is very, very interesting for us because, it'll give a very different perspective to many of us OBGYNs who have tuned in. We also have Dr. Angus Sulistiano for joining us, who's an OBGYN. Then we have Professor Tan, Dr. Hema, and So let us begin with our first speaker for today, Dr. Irene Castillo. She has obtained her Doctor of Medicine at University of St. Thomas in 1983. She's been serving as a medical practitioner for over 30 years. She's currently the Chief Section of Hematology and Head of Hematological Oncology at University of St. Thomas. And she was previously serving as Associate Professor, Faculty of Medicine and Surgery at University of St. Thomas. Her main research interests reflect in her wide range of publications in various journals, national and international, both spanning over 20 articles and papers, all in the field of hematology. So over to you, Dr. Irene. We look forward to hearing from you.
Good afternoon, everyone. I'm so honored to speak to our colleagues from different countries in Asia as well as in India. Today, I'm going to talk about iron deficiency anemia and how its outcome can be improved with the application of the principles of patient blood management. This will be the scope of my talk. We begin by looking at the scope of the problem of iron deficiency worldwide. Dr. Pai has mentioned the incidence of anemia in India, and this is the worldwide data that was recently published in 2019. Approximately 28.8% of people worldwide are anemic, which accounts to about 1.74 billion people. And the WHO has shown that the regions with the highest anemia
Recording in progress.
translates to about 1.2 billion people affected by iron deficiency. Approximately double that of patients with remarkable anemia. And so it may affect approximately about 2.4 billion people worldwide who may be iron deficient without anemia. And these are the population groups at risk for ID and IDA. We know infants and children are at risk because of poor nutritional intake. Adolescents are at risk because of the growth spurt the increased physiologic demands of growth spurt, and women of reproductive age, as Dr. Pius mentioned, are really at risk for iron deficiency anemia, and while the elderlies are also at risk for iron deficiency due to malnutrition and the presence of intercurrent illnesses. Knowing that these are the population groups at risk, it begs the question of, are we doing enough to prevent or to manage iron deficiency? Applying then the principles of patient blood management would probably help us better manage our patients with anemia. And through the years, the definition of patient blood management has shifted from a transfusion-centered approach to that of a patient-centered approach to managing the patient's blood problem. It used to be that PBM was known as a technique or a application of principles perioperatively, that is to reduce the need of blood transfusion during surgery. But the proponents of PBM has already noted that PBM is applicable not only to surgical patients, but they are indeed applicable to all patients, both surgical and medical. And it talks about managing the patient's blood problem, which includes screening, detection, treatment of the patient's anemia, while preserving patient's own blood means sticking to principles that would minimize the loss of blood during surgery, iatrogenic blood losses, and the like. We would also note that in this definition, there is patient empowerment. So we respect and recognize the needs, values, and preferences of the patient in terms of how his or her blood problem is better managed, so that there is some degree of patient empowerment in patient blood management. All in all, this brings towards a better or improved outcome of the patient's anemia. So then we move on to how does PBM apply to the management of iron deficiency anemia and anemia. So here we see the three pillars of PBM applied to iron deficiency or anemia. So it starts off with the detection and management of anemia and IDA. Then it goes on to the second pillar, which are techniques to minimize blood loss of the patient. And then the third pillar, which is optimization of patients' tolerance to the level of anemia. So we go to the application of PBM to iron deficiency. So it starts off with the routine detection and diagnosis of anemia and IDA thereafter. So did you know that almost half of patients with ID and IDA suffer in silence? Approximately 40% of patients with ID and IDA had no symptoms indicative of iron deficiency nor iron deficiency anemia. How then are we able to diagnose our patients? So it usually starts off with a simple CBC, and patients falling less than the recommended levels for normal in terms of hemoglobin, hematocrit by the WHO are then labeled as anemic. And so here for the different age groups, we see what it consists as normal. So for children, 6 to 59 months, it's 110 or so. 5 to 11 years of age, it's hemoglobin of 115 and up. Children 12 to 14, 120 or higher. For non-pregnant women, it's 120 or higher. Pregnant women, 110 or higher. And for men 15 years old and above, this would be normal. So any value less than this would consist of anemia. And so once we diagnose our patients as being anemic, then we go towards diagnosing whether they do have iron deficiency. And so these are the tests that would usually follow. So we need the serum iron, total iron binding capacity, transferrin saturation, the serum ferritin, and the red cell indices. The serum iron would usually be low, while the total iron binding capacity, which translates to the level of ferritin, transferrin, which is the carrier protein. But more importantly, we use these two values to compute for the transferrin saturation. Serum iron over the IBC gives us transferrin saturation, and a transferrin saturation of 20% or less is suggestive of iron deficiency, but a level of 15% and less definitely compatible with iron deficiency anemia. Serum ferritin, this is actually a little nuance in terms of how we interpret our serum ferritin levels. Different groups, different societies would have different levels as to what they would consider as acceptable serum ferritin level. But generally, for menstruating females, serum ferritin less than 30 would be compatible with iron deficiency. So it has already a high sensitivity and specificity that iron deficiency does exist. Now, there are proponents that would say for adult males and postmenopausal females, serum ferritin level less than 100 would be indicative of iron deficiency. I said the interpretation of serum ferritin is rather nuanced because we know that serum ferritin is an acute inflammatory reactant. And so the presence of inflammatory states can affect our interpretation of the serum ferritin. So that at times, acute phase reactants like C-reactive protein are even requested to determine whether the patient is in an inflammatory state. Now, the red cell indices may be used, but they only suggest it has a very low specificity for iron deficiency. So this is just to highlight the different stages of iron deficiency. I have been mentioning iron deficiency and iron deficiency anemia, and this is just to explain the two. So in a normal iron status, so the patient has a fully full iron stores and iron present for erythropoiesis, while once there is a beginning negative iron balance or iron deficiency, then iron stores are becoming depleted. Then we move on to a more severe stage, which is iron deficient erythropoiesis, or what can also be called as latent iron deficiency or iron deficiency without anemia, where there is now remarkable depletion of the iron stores, which may be reflected by the serum ferritin. And then we go on to the last stage of iron deficiency anemia, where the patient now is frankly anemic. And so here again are the parameters we make use of when determining whether the patient does have iron deficiency or not. And as you can see here, microcytosis or hypochromia or the low red cell indices is a late event. Now, although signs and symptoms in iron deficiency and IDA may be non-specific, these are typically the more common symptoms that patients would complain of. They complain of fatigue, headache, dyspnea, and pallor. Recently, this is an interesting paper. Korean retrospective studies show that hair loss can be a manifestation of ID and IDA. They have shown that patients with serum ferritin levels less than 70 microgram per liter was associated with hair loss. Serum ferritin concentration was lower in patients with female pattern hair loss when compared with normal healthy women. Patients with male patterned hair loss demonstrated lower serum ferritin levels when compared with age-matched controls. Patients with ID and IDA may also experience difficulties in sleeping. According to a survey of 2,400 consumers suspected of having ID or IDA, about 40% would complain of difficulty of sleeping. And the second study showed serum ferritin level less than 45 microgram per liter which is associated with a higher risk of sleep-wake transition disorders, including abnormal sleep movements among children with ADHD. The symptoms in IDA may be in a continuum. They may initially present with hair loss. They can present then with fatigue as the anemia severity deteriorates, or as the anemia becomes more severe. They complain of fatigue, restless leg syndrome, sleep disturbance, and pica becomes more noticeable when the patient has severe iron deficiency as well as cognitive impairment, which may manifest as poor performance in school, poor productivity at work, irritability, and so these are the typical manifestations of ID and IDA, which we may need to recognize. So what about treatment for our patients with iron deficiency? So applying the principles of PBA, aside from the detection and diagnosis of iron deficiency anemia, we should recognize that iron deficiency anemia is not a disease by itself. There is always a cause to it. And for women in the reproductive age group, it may be because of menstrual losses, the increased demands of pregnancy and lactation. But for males and postmenopausal females, we have to be aware that occult GI bleeding may be a common cause. And so these patients may need workup for the gastrointestinal tract. And so we need to identify the cause, and then we need to treat these patients with appropriate iron supplementation. So the WHO also recommends that population groups at risk may need some degree of prophylaxis against iron deficiency. And these are typically the age groups which the WHO would recommend supplementation. So infants, children, and adolescents, pregnant women. And as you can see from this following table, this would be the recommended supplementation by the WHO for infants, low birth weight infants, for young children to adolescents, for menstruating adult women and adolescent girls. Then it's usually a prophylaxis of 3 months in a year, particularly if they belong to areas where there is an increased prevalence of iron deficiency. Among pregnant women, the WHO recommends supplementation of 30 to 60 milligrams elemental iron as soon as possible and throughout pregnancy. But among women who come from areas where there is a high prevalence of iron deficiency, then the recommendation is throughout pregnancy plus 3 more months postpartum. So the treatment for iron deficiency would be oral preparations of iron supplements, or it can be intravenous preparation. So there are a lot in the market, and it may be our choice may be influenced by the patient's preference or presence of adverse reaction like nausea, epigastric pain, constipation. And then we also have a variety of intravenous iron preparations. In our locality in the Philippines, we have ferric carboxymaltose and iron sucrose only as our IV iron preparations. Now, here are some up-to-date evidence for the role of oral iron therapies. We do know that iron needs increase during pregnancy, but maybe some of us may not be aware that indeed it's a big 7 times more increase in the need for iron among patients who are pregnant. And this increase remarkably comes during the second and the third trimester. And failure to meet these iron needs predisposes mothers to postpartum IDA and may also impact the baby. Therefore, early testing is important and treatment to minimize birth weight-related outcomes among our patients. In a Danish study conducted to demonstrate the benefit of oral iron supplementation for mothers and children, they had a study which had about 119 subjects, and half of these were given iron supplementation and half were given placebo. They were started about 14 to 18 weeks of gestation until 8 weeks postpartum. And these are their findings. Iron supplementation had a significant positive impact on the iron status and hemoglobin levels during pregnancy up to at least 8 weeks postpartum. In pregnant women, it resulted in lower frequency of ID and IDA compared with placebo. It also had a positive influence on newborns' iron status, but it had no impact on the length of gestation, placental weight, and newborn's birth weight. Now, what is the role of our friendly gadget? It has also been shown that if women who have iron deficiency would have fortnightly mobile phone calls or reminders, then the compliance do increase. The compliance do increase for these patients. And so they did this study, very interesting, and we probably should be doing it for our patients whom we need to improve compliance. So those with gestational age between 13 to 28 weeks of pregnancy and diagnosed with iron deficiency, they use the mobile phone reminders. And with increasing compliance, they were able to show that those who had the reminder had a more significant increase in hemoglobin compared to those who did not get any calls at all. And so we see that the mobile phone really may have some other aids for our practice. Now, what about iron and multivitamin supplements improving infant outcomes? There is a systematic review which aimed to evaluate the different supplementation interventions on maternal birth, child health, and developmental outcomes. These are the benefits of single nutrient supplementation. If we give them single supplement iron, there is a 47% reduction in the risk of maternal anemia. There is also a 12% reduction in the risk of having low birth weight babies. Giving vitamin D reduces by 36% the risk of preterm births. Giving calcium reduces by 55% the risk of preeclampsia and eclampsia. There is also benefit to multi-nutrient supplementation. And 15%, it showed a 15% reduction in the risk of delivering a low birth weight baby, a 9% reduction in the risk of stillbirths, and a 7% reduction in the risk of small for gestational age infants. And so ultimately, the goal of iron and multivitamin supplementation is to ensure a mother that has a low risk delivery. What is the role of oral iron versus intravenous iron and when to switch? Of course, we know that the first line treatment for iron deficiency anemia would always be oral iron supplementation. But there are instances where there is a need to use intravenous iron. And this is when we need a more rapid response or when the mother or the pregnant woman is unable to tolerate oral iron. Compared with oral iron, intravenous iron results in more rapid, more frequent hemoglobin normalization, effectively depletes our iron stores, and is well tolerated. Blood transfusion, which we hope we do not frequently would need to resort to, should be reserved only for those with risk of further bleeding, imminent cardiac compromise, and symptoms requiring immediate attention. I think this is my last slide, and I will hand the microphone now to the floor to Dr. Pai.
Thank you. Thank you so much, Dr. Irene. Very, very interesting and really talk, which was a bit of an awakening for most of us. I think, certain things that you said, the numbers were quite mind-blowing. that 1.7 billion people are anemic in this world, and double that number, like 2.4 billion people are suffering from iron deficiency. So that really is huge numbers that we are looking at, and of course half of these are women. Another very interesting aspect, which as gynecologists we don't often address or have looked into, is the preserving patients' own blood for use in subsequent times of their life, like when they require surgery or maybe for their pregnancy later on. So this is very interesting and something we as gynecologists haven't really explored. Also, the focus on ferritin. Most people do hemoglobin, but that's probably a little late to pick up unless the patient has already become anemic. So a little focus on ferritin, again, I think was very, very important. And, how in our own countries, how we can supplement iron, how we can provide it to the people who need it the most. And one of the things which really hit me, though I'm a gynecologist and obstetrician, is the fact that iron needs increase 7 times more during pregnancy. I knew that the demands increase, but that it increases 7 times was really quite an eye-opener. So thank you for really focusing on so many important aspects of this hugely prevalent condition, which affects many, many of our women particularly, and of course the entire population. So thank you, Dr. Irene. And we can now move on to our next session. I have the privilege of introducing Dr. Agus Solistino. He is graduated in 1987 from the Faculty of Medicine, Erlanger University, Surabaya. He has a career spanning 30 years, and currently he's a consultant at the PPDSSI Fetal-Maternal Medicine in Indonesia. He's also the head of the division of fetal-maternal medicine at Dr. Setomo Hospital, Faculty of Medicine in Surabaya. So Dr. Agus will be taking us through some very interesting case discussions. May I have the next slide? Yeah, so and then we will have expert group of panelists to discuss this whole conversation. And we have Dr. Irene, whom you've just heard. We have Dr. Professor Tan with us, Professor Felix, who's a dermatologist, to give us a new perspective altogether. And of course, our own expert from India, Dr. Hema Devakar. So let's go on to the talk by our next speaker, Dr. Agus. Dr. Agus?
Yeah. Okay, thank you, Dr. Pai. Yeah, for your interesting discussion. Yeah, and thank you for Dr. Irene. It's very, very nice and very, very interesting lecture. I think it's easy for me to discuss after Dr. Irene give a lecture for us. Yeah. And good afternoon, all our colleagues here. And I will present my case in anemia and pregnancy. So this is Mrs. S. Mrs. S, 23 years old, and she came from Surabaya, about 5 kilometers in rural area from Surabaya, and she came. She referred from hospital to our hospital, because of the anemia and post cesarean section. She is on the second pregnancy with 1 para and live. So she came in our hospital in the 35 and 36 weeks of gestational age, and from obstetric history, she said that she had a cesarean section because of the prolonged labor in other hospital, in about 1.5 years ago, and now in current pregnancy. She is a housewife and education only from primary school, and she is on the low socioeconomic status. On history of the diet, she said that she don't like that vegetable and fruits, so the foods menu is very little with vegetable and fruits, I think. And family history, there's no history of family anime and family, and also in the past medical history there is no disease. Yeah. So in recent medical history, on April she had a missed period on 1 month and pregnancy test was positive. Yeah, she didn't go anywhere because there's no complaint. Yeah. On June until September 2022, she went to public health, Wiyung Public Health in Surabaya, and there's a normal blood pressure. And on September, she came to public health center, and she looks pale, and she said that she feels fatigue with normal exercise and dry skin and hair loss on the few days. So the first on June, she went to public health center with normal blood pressure, and she from public health center gave her ferrosulfate 2.65 milligrams and calcium lactate. Yeah, and from laboratory result in public health on June, the hemoglobin is at 10. Yeah, so only mild anemia. And then from a public health center refer her to the hospital, but she was and family refused go to the hospital because there is no complaint at all from her. So like what Dr. Irin mentioned, that's the anemia is not always had a complaint or had a symptom or yeah. And then after she feel after that she had fatigue in normal exercise, and a few days before they had hair loss and dry skin, so she went to hospital. Yeah, and from hospital on the public health, she go to the public health, and on September, the hemoglobin was 7. So from public health 7 sent her to hospital, a little hospital in rural area of Surabaya, and then from this hospital and their hospital gestation was 29 weeks, and for confirming diagnosis of the anemia and for the therapy, so they sent to refer to Swandi Hospital. Yeah. So in Swandi Hospital, in our hospital, yes, the general status was the KCS is normal, and she looked pale and dry skin. The blood pressure is normal, heart rate 104, respiratory rate is normal. Yeah, and core and pulmo is also normal limit. Abdomen is okay. No organomegaly. There is no splenomegaly. Yeah. The weight of the patient was 42 kilograms, and the height is 147 centimeters. So BMI was 19.4. So this is the normal, but low normal, I think. Yeah. In Swandi Hospital, we performed ultrasonography. From sonography, the biometric was 31 and 32 weeks of pregnancy, and estimated weight was 1,500 grams. This is below 5% if we differentiate with last menstrual period. So in last menstrual period, the gestational age was 35 and 36, but from ultrasound was 31 and 32 weeks. So the fetal is lower than the normal on the last menstrual periods. The amniotic fluid is 6 centimeter for AFI, amniotic fluid index. So this is a slight oligohydramnion. And from the laboratory results, the laboratory say that the hemoglobin was 5.8 and hematocrit 17.4, MCV 72.2, MCH 19, MCHC 26, yeah, and leukocyte was 17.860. So from status of the obstetric, yeah, we there is fetal heart rate is normal. There is no contraction of the uterus. So we diagnosis as a second pregnancy with paraben and live one, 35, 36 week of gestational age. Yeah, cephalic presentation with the previous of cesarean section, severe anemia with 5.8, slight oligohydramnion, intrauterine growth restriction, and estimated fetal weight was about 1,500. So the plan hospital sent to hospitalize for the patient, and we do the laboratory test for the serum iron, the TIBC, ferritin, blood smear, yeah, and we plan for the transfusion because of the severe anemia, and this is on the 35 weeks of pregnancy. So we plan blood transfusion, and then we consult also to the internal medicine, yeah, and we gave intrauterine resuscitation for the fetus, yeah, with intravenous dextrose and oxygen and lateral recumbent, and then we give also lung maturation, yeah. From internal medicine department, yeah, said that this is anemia gravis and leukocytosis due to inflammation or infections. So they give manage with oxygen and transfusion for the PR packed red cells 2 bags per day until hemoglobin reach 10 gram per percent, and give folic acid and blood smear. From blood smear, said that this is a normochromic, partially hypochromic, microcytic anemia and leukocytosis due to iron deficiency and infection or chronic disease or thalassemia cannot be ruled out yet. So they advise that to test the serum iron, the TIBC, ferritin, and electrophoresis hemoglobin. This is the serum laboratory results. This is from 25 October. This is the 5.8, and then our give transfusion. This is 8.2, and after transfusion again, there's a 10.4. Yeah, and this is from electrophoresis. This is the HbA 91%, and HbA2 was 1.6. So there's no thalassemia. Yeah. On this day, on 29 October, she felt the abdomen was cramped, the uterus was, there's a contraction of the uterus, and we did a cardiotocography. So, and the cardiotocography said that there's abnormal CTG, and from the ultrasound said that there's biometry 32 weeks and have a severe oligohydramnion. So oligohydramnion, yeah, and estimated fetal weight was 1,500, about that, and for the Doppler velocimetry of the artery uterina, as there is a high resistance and brain sparing effect from the artery umbilicalis and mid cerebral artery. Yeah, And from vaginal examination, there's a dilatation 2 centimeters and effacement was about 50%. So we diagnosed it as a second pregnancy, single with one life child, 35, 36 weeks of pregnancy, intrauterine singleton pregnancy, cephalic presentation, previous cesarean section, anemia was corrected, now 10.4, fetal distress and severe oligohydramnios and IGR. So because of the fetal growth retardation and fetal distress, so we make emergency cesarean section and born fetal, female 1,700 gram with Apgar score for 1 and 5 minutes were 4 and 7 and blood score 36 weeks and Lupchenko score below 10 percentile. So the baby was small for gestational age. During operation, there is the contraction of uterus is there is no contraction. So the uterus was hypotonia or atonia. So after we know that's atonia, there's a loss of the blood, blood loss, yes, about 1,200 milliliters. So there's a postpartum hemorrhage, early postpartum hemorrhage due to atonia, uterine atony. So we perform with the uterine compression suture, which our methods, Surabaya methods, And after we perform compression suture, the fluxus was stopped. After operation, we check the blood pressure is normal, and heart rate was 108. Hemoglobin was 7.4. So we give blood transfusion, and then on 30 October, the hemoglobin was 9.5, and to November, she discharged from the hospital with a good condition. So this is the resume of our of my presentation. So this is a journey of the pregnancy. We know that in pregnancy we had we should have a safe pregnancy before the woman got pregnant. So and in pregnancy there's we have several period. The first is before she got pregnant on periconceptional period. So we should prepare the woman for the safe pregnancy. And if there's abnormality, so we do the manage for the pregnancy. And there's the second period, and after conception and implantation. And then the first trimester and the second and third trimester, and then on labor and after labor, postpartum. So there's so many problem and that's besides for there's also before she got pregnant. So we should also check the woman, and after postpartum period, so we should also examine the patient. And the first, I think, for the goal of the safe pregnancy was the before the woman got pregnant, so we screen for the iron deficiency and iron deficiency anemia and CBC and ferritin. If there's okay, so the pregnancy it will be safe. But if there's an anemia, so we should give supplementation, food supplementation, micronutrient, and iron tablet. And if and after she got pregnant, if there's an and screening was anemia. So anemia is mild or moderate in the first trimester. So we should give iron tablet. But if in the second or third trimester, second trimester, so we should check again the laboratory tests and for the iron deficiency and anemia of iron deficiency with CBC for the MCV and ferritin. If there's a mild, we can give iron tablet, but if the moderate or severe, we should give the iron IV, or if near 40 weeks of pregnancy, we give transfusion because of the immediate of the correction of the hemoglobin. In postpartum and in labor, if the patient in labor, there is also there's a problem because if anemia in labor, so there's maybe make some complication of the labor, like prolonged labor or increasing of the cesarean section. And postpartum, there's a problem from if there's anemia, so make risk of the postpartum hemorrhage because of the hypo or atonia uterine. Before pregnancy, we should check about the woman if there is maybe there is some problem with nutrition, environment, infection, age, and like teenagers, parties, birth interval before 1 year, or education, or social, and chronic energy deficiency, So we should give supplementation, food supplementation, iron tablet, preparation for the healthy pregnancy. So we should manage before she got pregnant. And if postpartum, so in long term of the complication of the anemia, so we should give the food supplementation, iron tablets, minimum 3 months after partus, after giving birth, and preparation for the next pregnancy, preparation also for the child, for the growth and development. I think this is my last presentation, Dr. Pai. Thank you. I give back to you. Thank you.
Thank you. Thank you so much, Dr. Angus. This was really, really thought-provoking case. And I agree that in each of our countries, there are many times that we see situations such as these, especially amongst the socio-economical, slightly backward group of patients. Can I request you to give me the resume of our panelists again, because we have some very, very very well-known panelists with us today. Dr. Irene, you all have been introduced to already. And then we have Dr. Hema Divakar from India, from Bangalore. Very, very well known for her work in obstetrics gynecology, as well as for the social work that she does. She has a huge organization called Artist, where she really does a lot of work, outreach work, reaching out to underprivileged patients. She has been the president of the Gynec Federation of India, Gynec Federation of OBGYN. So very, very accomplished lady. Dr. Hema is with us. And we also have a leading dermatologist, Dr. Felix from Malaysia, who's joining us. And like we interestingly noted, there are many different symptoms of iron deficiency anemia, not only the weakness and the fatigue that we see, but also dermatological concerns. So may I then bring our panelists forward today and take their ideas. We have also Professor Tan with us. Professor Tan is a medical director at the the visiting senior consultant at KK Women's and Children's Hospital. He's also adjunct associate professor and founder, clerkship leader in Duke NUS Medical School. He has conferred several teaching and clinician award in his career, including the inaugural Singh Health Golden Apple Award for Outstanding Educator and the Singh Health Distinguished Educator Award again in 2018. And his research interest is in reproductive endocrinology in first trimester miscarriage. So that's a very niche area that Professor Tan is focusing on. So do we have all our panelists here? Wonderful. So if I can just throw open the stage to them right now with a very broad question on what really are your thoughts in this particular case? Anything which just jumps to your mind about this case? Kindly feel free to unmute yourself and please give your ideas and opinions. Panelists?
Hi, maybe I can start first.
Yes.
Thank you, Professor Agus, and for the presentation. So just now, Dr. Frishma talked about the iron deficiency anemia being a third world country issue, but that may not be necessarily true as well, because in Singapore, Singapore is considered one of the richest country among the Asia country, but in our latest study that we published, this is the GASTO data. So Singapore actually has a longitudinal study which we follow up patients from pregnancy after the delivery. In fact, the study is still ongoing because the cohort of the pregnant lady and the kids will be followed up until they are in their middle age, until the kid reaches into the 40 years old. So we are trying to see what has happened in pregnancy, whether does this impact the kid in the school and also later on as adult as well. So in that study that we have done, our incidence of iron deficiency is as high as 50 to 60%.
Wow.
Even in Singapore, within our population as well. I mean, we are definitely not in most of them are not really in poor country. But the iron deficiency is still a major problem. So for me, I screen all my patients for iron deficiency. So I use the ferritin as my screening level. I screen them from first trimester, second trimester, and third trimester using a cutoff of 30 as the ferritin, below 30 as iron deficiency, and below 10 as severe iron deficiency. And even in my own patients, I think at least 50 to 60% of the patient I picked up is iron deficient. I think I also want to stress here that hemoglobin and MCV is not the best way to screen for iron deficiency, because a lot of women can be iron deficient unless they are very, very severe. Like in this case, the hemoglobin can still be normal, but they're severely iron deficient. So I think that this case brings out a very pertinent point that iron deficiency is a major problem across the whole of Asia. And to this, I think I want to thank P&G for taking this effort to address this issue, because I think this is a problem that's seen within the entire Southeast Asia. And in our GASTO study, we find that amongst the Indian and the Malays, there are more at risk of iron deficiency compared to the Chinese population. And I think in our Southeast Asia countries, especially Indonesia and Malaysia, this could be a major issue as well.
Thank you, Professor Tan. That was really an eye-opener to know that even in countries such as Singapore, with all their wealth and progress, there still is huge quantity of patients with iron deficiency. So thank you for that. And While we're talking about it, you said you screen your patients with ferritin. In India, and I guess many of the other countries, we have a lot of problem with patients coming in for pre-pregnancy counseling. Almost nobody comes in pre-pregnancy. They come in when they're already pregnant. So is there anything we can work on? Any ideas how to bring in patients for pre-pregnancy counseling so that we can then check them and actually correct their anemia or iron deficiency before they even become pregnant? And that would be a really good way of taking them into a safe pregnancy. Do we have any suggestions for bringing patients in for pre-pregnancy counseling? Hema? We can't actually.
Yeah, can you hear me, Rishma?
Yes, now we can.
Yeah. Hi. In fact, our parent organization, Foxy, had a program called 12 by 12. Every girl who is 12 years old should have her hemoglobin at 12 gram%. So that was a great movement in the country. And following that, we had a major initiative with UNICEF as weekly iron folic acid supplementation in schools. So like a dot therapy, that is under observation, 1 tablet of iron folic acid into every girl's mouth every Monday by the teacher, and the Parents Teachers Association getting together to tell them more about the diet, the hygiene, the hand wash and the clean drinking water, the nutrition, everything that goes around with us. So if you start from that age, they are empowered with some knowledge and education, some sensitization is occurring right across a couple of years before they embark into pregnancy. Rishma, an interesting thing in the case that he presented was, leave alone the pre-pregnancy stage. Within the antenatal period, it was written in red that this patient went missing for 3 months. So she's in the system, but she's not found. So, it's so real, the ground situation, and therefore the government has now made it mandatory for 4 antenatal checkups. The patient cannot go away missing. She has to deliver in the institution, and the Anemia Mukta Bharat guidelines say when she's available to us, at least then do your best. The pre-pregnancy target, a lot of social media activity also on empowering the girls and the youth of the country in their own languages. We reach out to them so that they understand and they come 2 steps forward. Well, we try to do our best. And anemia and menstruation are linked like 2 sides of the coin to each other. So once you fix the anemia, you should also fix the menstrual problem.
Correct.
Then you are doing a comprehensive thing. The last thing I want to say, Rishma, is the 6-pronged strategy which the government has adopted. Now we are no longer working in silos. It is everything integrated. Our president, Dr. Pai, has used a word called Ekikaran, which means integrate everything. It is the sector of stakeholders of education, sanitation, supply chain, everything together. And the 6 prongs include treatment of infections like malaria, deworming, delayed cord clamping, of course, the supplementation of the iron folic acid tablets, and to take care of several of the preventive measures as a wholesome approach to this entire issue. And to my mind, when we say we do not have to celebrate the World Iron Deficiency Day anymore, that will be the takeaway from this kind of a meeting. Yeah.
Thank you, Hema. I think you've put together so many important points. And I agree that we need organizations, gynecological organizations, HEMAT, DERMAT, all these organizations to also do a lot of good work, as well as our governments, and each one of us committed workers, health workers, to actually bring about a change in this field.
And coming back, Reshma, is make your practice anemia free. At any touch point, any frontline healthcare workers, it's their responsibility to see whoever they encounter, they have to be in the pink of their health. So that is the kind of a mission mode we have adopted.
That is a target for each one of us here. Pink of health is what we have to achieve for all our patients. So my question is, very practically, what doctor presented, that this patient just refused referral. Most patients want to just be in the, in the little area around their home. They don't want to go to distance to travel to go to a hospital. So do the patients even recognize these potential implications of iron deficiency and anemia, and what they can actually face, what are the dangers they can go through because of that, and how do we actually convince them that this is really important? So I guess many of us have this problem that we face, that the patients are, don't listen to us, don't want to go to a referral center. And like Hema mentioned, in India now, majority of our patients are delivering in hospitals. And that's a huge change that has happened from a majority of our patients delivering at home or in the nearest health center. So most of our patients are delivering in good health setups. So if anybody has any ideas about convincing patients, but
I have a lot of things to say, but I'm just happy for the others.
Yeah. Please feel free to unmute yourself and give an opinion. Also, yeah, Hema, you want to say that?
Yeah, I was saying that, counseling, talking to people, sensitizing them as to what problems the state of anemia can bring in throughout their life course, both to the mother and the baby, because if the mother is anemic and that we do not handle, then her baby will be low birth weight, stunted growth, and it continues through the adolescence. It's the entire life course which is affected. And also the malnutrition, anemia status will sow the seeds of chronic NCDs in future. The mother as well as the baby can have the programming for the future cardiovascular diseases and hypertensive disorders and diabetes inclusive. So there's a lot more than what can meet the eye, apart from the short-term problems that we all so very well explain to our patients and the family, but the time and huge volumes are a constraint. So we have to think out of the box about whom we can use to convey these messages and how effectively these messages have to be conveyed through every platform and every media that is available to reach out to the community, thereby the mothers and the children.
So basically also use technology. It doesn't always have to be one-to-one transmission of information. Use technology. Dr. Arun spoke about the mobile phone messaging, which is wonderful. I have another issue that I often face. Patients who come to us in the first trimester, they are so nauseous, they're throwing up all the time, and they're just not taking in adequate nutrition. They already have entered pregnancy, anemic or iron deficient, and then the first 3 months completely going waste. Any recommendations for this first trimester, how we can improve their status despite the discomfort they're going through? Hema, you're muted.
Okay. So, from the FIGO, as a chair of the Well Women Healthcare Committee of FIGO, there is a simple checklist called Think Nutrition First, because we have noticed right across the healthcare providers, 80% of the times, the nutritional history and the recall is never ever taken because such a least degree of importance is played. It's a quick checklist you can administer in 2 to 4 minutes, but thereby you recognize what this patient is actually having in her daily diet, what is it, the gap that we have to emphasize and fulfill, etc. So this also has to ideally start at all points in time in the community, so that pre-pregnancy she is better prepared. And during the first trimester of pregnancy, there are many Indian home remedies as well. If the large joint families used to always reassure each other that such things happen, and then you flavor your drink or the water with such and such a thing, and what she likes to eat, she eats in plenty. And of course, there are some quick fix supplements that are given. But having said this, throughout the pregnancy also, the question is always asked to the clinician, what should she be eating and what she should not be eating, and most often it's pushed under the carpet and some vague kind of advice which is not practical, because especially in India the cuisine is so complex and different in different geographies. So we need to understand what the staple food is, and our Prime Minister has declared 2023 as the International Year of the Millets. So we are shifting from high carb to millets and high proteins. So that is again another huge sensitization which is happening. So all in all, maybe the first 3 months, you may not get to the optimal state of nutrition. There is also a tendency to offer protein supplementation and B12 supplementation, especially to the vegetarians in the country. So we are beginning to pay a little more attention to the nutrition as it should be. And I think in the days to come, it'll be a more structured approach to this, Rishma.
Thank you. We all know that, pregnancy is one area we really focus on, but we also know that there are so many different symptoms of anemia and iron deficiency anemia. And Dr. Irene mentioned also about hair loss, which is something new that everyone's talking about, hair loss because of anemia, male and female pattern of baldness, dryness of the skin. So, we'd like to hear from our expert, Dr. Felix, what are his opinions on this, what information he'd like to give us regarding this.
Yeah, thank you, Dr. Pai. So, in terms of iron deficiency, we can divide iron deficiency into those without anemia and those with anemia. Basically, skin manifestation, the one that we typically teach our medical students is those with severe anemia, those with high, long-standing iron deficiency causing spoon-like koinonia, dry skin. All these are the severe spectrum of anemia, the pallor and all those things. But if you look at iron deficiency per se, before it goes into the anemic stage, a lot of time we look at patients presenting with anemia. There's a lot of evidence showing that iron deficiency not amounting to anemia causes a lot of hair loss. There are two particular type of hair loss. In particular, we look at iron deficiency. First is the telogen effluvium type. The telogen effluvium is the one that you get a lot of hair loss, especially after a certain trigger. The trigger can be delivery, it can be stress, it can be infection. This type is propagated by having iron deficiency per se. And these patients usually have tons and tons of hair loss. Every time you comb your hair, there will be hair loss and there will be a bulb at the end of the hair. So these are the telogen hair that are actually in the resting phase. The other type is the immune mediated kind that presents with patchy hair loss, telogen alopecia areata. There are sparse evidence showing that alopecia areata might be associated with iron deficiency, or iron deficiency actually worsen alopecia areata. So in this subset of patients, either those with alopecia areata, especially in the females, and also telogen effluvium, we tend to give them iron supplement. If you do their ferritin will be lowish, their serum iron will be lowish, not amounting to anemia per se, but supplementing these patients with iron supplement will actually help in the recovery of this condition. Of course, when you look at the natural history of both alopecia areata and also telogen effluvium, this type of hair loss are self-resolving. It takes between 6 months up to 3 years for the condition to resolve. But supplementation of iron actually will hasten the recovery of all these patients with this condition.
Thank you, Dr. Felix. That was really an important highlight, because that's one thing which really brings the patient to the doctor. If the lady is losing hair, she will actually come and seek a opinion, because that's something very important to her. So thank you for bringing this important correlation together. Another very important thing, and Dr. Irene, I'd like to bring you in here. How do we actually prevent transfusion? Most of us and patients themselves are very reluctant to receive blood transfusions. So what is our strategy to try and prevent blood transfusions? Like the case presentation, we had to give multiple transfusions to the patient, and that's what we want to avoid. Dr. Irene?
Yes. So I just like to bring in the principle of patient blood management into the management of these patients' anemia. First of all, you said the first pillar would be the detection. So the patient was indeed detected to be anemic. And the second part is trying to prove that this patient really has iron deficiency anemia. And so I guess early on, the iron studies should have been done so that the patient may have been adequately treated already at the start. But I understand that in a lot of centers, even here in the Philippines, iron studies may not be available. And so what do we do then? How do we try to manage these patients who look like she has all the risk factors for developing anemia? And so I guess we can do a therapeutic trial of giving this patient higher doses of iron, like 2 or 3 times a day, and seeing how she will respond to it. And so in the absence of laboratory tests that will tell us that she is indeed anemic, then we can do a therapeutic trial and try to monitor whether we are getting the response that we should be getting with the treatment that we are giving. Now, this next question about blood transfusion is actually going to the third pillar of patient blood management. We try to see how tolerant the patient is of the severity of her anemia. Here, this patient really showed like there is some degree of cardiovascular compromise. She has tachycardia, she has fatigue, and maybe the obstetricians would be able to tell me whether the severity of anemia is already compromising the fetus in terms of a small for gestational age infant. But if we are to try to see how much transfusion we are to give this patient, the rule is we do not run after numbers for the improvement of the anemia. We are trying to improve the physiologic status of the patient. And so if 1 unit packed RBC is adequate already to improve her sense of well-being, the tachycardia would improve, the appetite would improve, then 1 unit packed RBC should be enough. I'm sorry to say that maybe I do not know if the obstetrician really has a rule of what is a safe hemoglobin level. But actually bringing the level to about a level of 80 or so would probably be safe for the patient. And thereafter, the medical management or the pharmacologic management of the anemia should follow. And unfortunately, this patient appears to be really poorly compliant. She keeps on being out for so long. And so thereafter, the question of intravenous iron towards the latter stages of pregnancy should also be considered so that transfusion may be avoided.
Thank you. Thank you, Dr. Irene, because, it's very, very important for us to avoid transfusion as much as possible and to minimize it, again, whenever possible. So let me just have Professor Tan come in for one last question before we go to some of our listeners who are sending in some questions. So can you give us some tips, Professor Tan, to prevent iron deficiency and anemia in pregnancy? What is it that you advise? What are the tips?
I think early screening is important.
Yes.
Screening for their iron level. So we can screen it when they come for preconception, but certainly at first trimester when they booked in, we should screen them for iron deficiency and iron deficiency anemia. Second thing is the first line of iron deficiency usually should be an oral iron an oral iron that has high level of elemental iron. So I will encourage like a product from Saint-Gobain, which has 30 milligram of elemental iron. Not just the elemental iron has to be high, the side effects to the patient must be low. Because if the side effects to the patients are high, then they will not be compliant with the medication. A very common side effect of iron supplements is actually constipation and bloatedness. These are two common side effects that actually makes the patient very non-compliant. So like using Saint-Gobain, which has a very low side effects, I usually also add on a probiotics for them when they take iron as well, because it actually does reduce the side effects of constipation and bloatedness. So usually I advise the patient to take both, and generally their symptoms are much less. So I think we have to look after, screen the high risk one, and also look for effective treatment. I think the last thing I would do, like what Dr. Irene said, if by 35 weeks I see that hemoglobin is still less than 10, I would definitely transfuse them with intravenous iron, because that will actually bring them hemoglobin up to about 11 at their delivery, because our target will probably be to avoid a blood transfusion during the delivery.
Correct. Thank you. Thank you so much, Professor Tan. As you know, we have a live audience in Bangalore, in Malaysia, in Philippines, and some of our live audience from Malaysia do have some questions. So can we bring them in?
Yeah, Rishma, I just wanted to park some important practical points for the oral iron usage, especially in our own country, because there are issues of counseling even there, because they should not take the iron and calcium tablets together. They should not have tea after ingesting the iron tablet. The supari or the phytates will come in the way. Fluorosis or fluorides in the water, which impair the absorption in certain geographical places in our country, it's to be kept in mind. Chronic intestinal infection, deworming, all of these, they make the whole oral iron issue so complex and so not ineffective in a way. So all of these simple, doable, counselable messages has to go to the public. Yeah.
So it's not a simple problem or any simple solutions here. Malaysia, can you come in? We would be happy to have you ask the experts your questions.
Aida Khaluk from Malaysia. First of all, I would like to thank all the speakers and panelists for their very insightful and informative presentation. I have two questions on behalf of the Malaysian participants. Number one, this is more a practical question. For a clinician, how do we assess pallor or paleness in a dark skin patient? So that's one. And number two, for pregnant women who requires transfusion in pregnancy, is there any precautions that you would advise the clinician to take? Thank you.
Any of the panelists want to take that? Yeah.
The question of how to detect pallor in dark-skinned individuals, I think that really is difficult. But we look at the conjunctiva and the nail beds and the palm creases, and that would tell us whether there is indeed pallor or not. So it's the conjunctiva, the nail beds, and the creases of the palms would tell us whether there is anemia in our patients.
Correct. And the second question?
I'm sorry, I did not get the second question about transfusion.
The second question is, if we are to transfuse blood into pregnant women, obviously during pregnancy, is there any precaution, or do we do it differently than non-pregnant women?
I don't think there's any difference between transfusing a pregnant patient versus a non-pregnant patient. I think it's the same. We do the pre-transfusion testing prior to transfusion, and so if everything is good with the pre-transfusion testing, then I think we're okay.
Great. Thank you, Dr. Irene. There's another question about how long is it permissible to consume the iron supplements? And if the hemoglobin is around 10, 11, but not 12, can we just increase with nutritional food rather than supplements? So how long do we really continue iron supplements?
Maybe I can take that question. So
Yes.
if you take a product like Saint-Gobain and the elemental iron is about 30, usually the hemoglobin will increase about 1 gram in a month. So usually about you take about 1 month to increase the hemoglobin about 1 gram. Some food we know does contain iron. I mean, of course, the red meats do contain iron, like beef, pork, lamb, But the elemental iron in this meat is actually really quite low, even though they are the highest. It's about 5 milligram. If you take a good portion a day, if you take a good portion. So you can see that the elemental iron is, the iron from food is actually really low. And not forgetting, our intestines are very bad in absorbing iron. Our intestine is not actually efficient in absorbing iron. Of all the iron we take per day, only about 5% of the iron is being absorbed, and 95% of the iron is passed out by our digestive system. So I think that this is something that we probably have to understand, that food alone, if the patient has anemia, might be very difficult to actually replace them just by food alone.
Thank you. Thank you. I think we have one last question, and that is on how important is it for an infant to be given iron supplements. So infant is a very special focus area. So anybody has a suggestion for that? Supplementing infants with iron?
No, for the breastfed infants, of course, if the mother is well nourished, and then it's through the breastfeeding. That's why it's one of the great advantages of the breastfeeding. But now there is a new nanotechnology through which they're bringing in transdermal oil to be applied on the delicate infant skin, so that the iron is directly absorbed through that. So in KM Hospital in Mumbai, they've done a large study, and the government is exploring it in 9 other districts, and we have to see how it goes, because that may be one of the simple doable mechanisms for the same.
Thank you, Dr. Hema. So at the beginning we had a little technical glitch and we couldn't play a very important video, so I'd ask the host to please play that video for us. Meantime, I'd of course like to thank our panelists for this absolutely interesting interactive discussion. I think we could go on for the next hour with all the questions and answers by the experts. But thank you so much, panelists, for joining us. And we'll now have the video playing for us.
One touch can bring back the will to live. One smile can spread cheer. One nudge can be someone's strength. Because healthcare is human care, and it does not limit itself to just medicines. It is about understanding pain before painkillers, temperaments before treatments, and the person before the patient. This is made possible by a science far superior than any other. A science that goes beyond treating illness to creating a world of care and wellness. The science of human care. We know. Because this understanding is the core of our innovations and the crux of our legacy. It gives meaning to our medicine. It inspires us to create world-trusted, highly recommended, irresistibly superior quality products that help empower patients and consumers live healthier and more vibrant lives. Healthcare with human care. PNG Health, the science of human care.
Thank you. Thank you for that. And with that, I have the pleasant task of thanking all of you. Thanks a lot to PNG really for bringing together this wonderful group of experts from different fields, from hematology, dermatology, and obstetrics gynecology from across our region to share their experience with us. Thanks, of course, to all of you who have joined online and those who are physically present in India, in Bangalore, in Malaysia, and in Philippines. Thank you so much. Let me end by saying, take care of your body. It's the only place we have to live. Thank you. Thank you so much.
Thank you. Is this slide share? Shall I?
Yeah,
Or you want to announce first?
Yeah. Okay. It's already 4:15 actually.
हाँ तो फटाफट कर देंगे ना.
No, no, India, only India.
India, but other places also, not only this.
Not only this, other places also.
Complete full India. Introduction आपको करना है मैं उधर जाके दूँ?
Yes, ma'am. I'll call you on the day. Yeah. Very good afternoon, doctors. I, Dr. Vinod from PLG Health Medical Team, would again like to welcome you all for this India-specific session. The past 1 hour, 1.5 hour of scientific program was relayed across India and the different Southeast Asian countries. We have this physical event in Bangalore, and we are connected 5 different satellite centers from South India, namely Salem, Namakkal, Bendigal, Warangal, and Belagavi. We also have live audience. We are having 1,500 of doctors watching us live on Medisage platform. So to begin with the India-specific session, I would like to call upon the speaker, Dr. Hema Divakar. May I request Dr. Divakar to be at the podium, please? Dr. Divakar is a senior consultant obstetrician and gynecologist at Divakar Specialty Hospital, Bangalore. She's having over 3 decades of experience in the field. She is the co-chairman and CEO of ARTIST, that is Asian Research and Training Transfer, member of Technical Advisory Board to the Ministry of Health and Family Welfare Association. She is the member of FIGO, that is the International Federation of Gynecology Labs. She is a national coordinator for FIGO Foxy PPO LCD initiative and also the co-chair FIGO GDO working group. And she has numerous publications on her name. So with this, I would request Dr. Hema Divakar to be at the podium, please. Our next speaker is Dr. Jyoti J.S., a senior OBS and gynae at Bangalore. Dr. Jyoti is practicing as the head of the Department of OB and GYN at Royal Medical College Hospital, Bangalore. She is the Vice President of Bangalore Society of OBS and gynae. She is the member of Food, Drugs, and Medical Surgical Equipments and Gynecology Committee of FOXY, and also a member and secretary of the Safe Motherhood and member of the Preventive Oncology Committee of Karnataka Society. And she has rich experience in clinical trials as a personal investigator and numerous publications again on this name in various national and international journals. Dr. Aware, as this is an accredited program, we have Dr. Ahuja on the line. She is the secretary from Indian Medical Association Maharashtra branch. She wants to provide some keynote address to the delegates on call. So over to you, Dr. Ahuja.
Video.
Sir, your voice is not clear. Hello. Doctor? So, doctor, this is Sriram from Salem.
We are unable to connect with Dr. Ahuja. As we have few different satellite centers, so please allow me 2 minutes of your time to quickly introduce the moderators, the local moderators at satellite centers. We have Dr. S.F.R. Patel at Bengal, a senior consultant at at City Hospital. We have Dr. Sandhya Rani from Warangal. We have Dr. G. Amalabadi from Delhi. Dr. M. Chandra Swami from Malakal and Dr. Divya G. Salam from Salem. So with this, I would request Dr. Hema Divakar to start the presentation on improving patient outcomes in PPH, postpartum hemorrhage.
For all my beloved colleagues who are present here physically, ellarigu namaskara, and to the other from the Simply South and Simply Superb, Vanakkam, Namaskaram Mandi, and all of those formalities of the greetings. Improving patients' outcome in postpartum hemorrhage is what I'm going to deliberate on. Can anybody in obstetrics say that we can avoid the bleeding totally? As it's commonly said, obstetrics is a bloody business, because even in the normal deliveries, without any complications, the patient has to lose some blood. How are we tackling this tsunami of preventable deaths? Something which we cannot be pardoned for. There are many, many missed opportunities, and ladies and gentlemen, let's pick our thoughts on those missed opportunities where we should feel really responsible, introspect, and see what better we could have done. With anemia being the leading cause of maternal mortality in countries like ours, 20% of the times. Just imagine if you would have had her in a state of good hemoglobin, a little bit of blood loss wouldn't have cost her life. So 20% of our mothers would have been saved in 30 million deliveries that are happening in our own country every single year. It is a given that every other patient that we see is anemic. And though we may not have the hi-fi kind of a screening modality in every nook and corner of our country, the basic history taking, the basic nutritional record, the clinical examination, that itself can be a pointer for you to start thinking and treating her. And the least you can do is the hemoglobin and the complete blood count. And of course, you add on the ferritin and electrophoresis as the case may well require. The case which was presented earlier this afternoon already alluded to what kind of outcomes we can expect in a case where the mother is anemic. where the low birth weight, neonatal morbidity, reduced iron stores, learning disability, all the way across the life, it has its impact. And for the mother, not only the loss of life, but many unseen and unsaid things, inclusive of the postpartum depression and delayed wound healing, reduced breast milk quality, and the repeated infections that she may get, low immunity and susceptibility to so much that she need not have born to. The Ministry of Health and Family Welfare, well, being the technical advisors, we are often questioned, why haven't we able to get a handle on anemia? Why are we talking about it since the last 2.5 decades? It's a whole vicious cycle. We correct the anemia in the available target of pregnancy, for example, but 30 million newborns again into this vicious cycle of anemia every single year, and it goes on and on and on. So we need to get out of this some time or the other. The coverage of iron folic acid tablets across the country has improved enormously, but the social factors that go with it, the stool becomes dark, they think the baby will become dark. They think you're energetic, the baby is large and you cannot deliver normally. Even these hearsay and misconceptions have to be squashed and nipped in the bud if you need to improve the compliance of the oral, besides the adversities of the side effects and the tablet size, etc., which we also need to pay attention to. Important to remember, like how we say take home messages, take home baby, take home mother is not the end of it all. The 6 months postpartum also, she has to have the supplementation. And in the case that was presented, that was a case of previous section. Nobody may have seen her in the interval period. That was a key point where they could have corrected her anemia. The antepartum anemia, the pre-pregnancy is a target. Many times we blame the patients or the girls who haven't reached us before pregnancy, but at least in pregnancy, in the 9 months available to us, we absolutely have to do our best to correct the state of anemia. This is the ideal scenario for a variety of reasons. We've not been able to do our best yet, but there's always a hope with the digital platforms, with the newer modalities, with non-invasive hemoglobin tests. Just imagine in the COVID times, anywhere you went, they would just put a digital thermometer to check your temperature, even in the airports and the theaters and everywhere. There's non-invasive hemoglobinometer, like a pulse oximeter. If you can just place it on everybody going everywhere at any touch point, you would pick up the trends of the pockets of anemia, and many more people may be sensitized to that. So the oral doesn't work. Then as a quick fix methodology, you need to, in the available time, get her to have a better hemoglobin. So you resort to the injectable. So the two commonly used injectables, iron sucrose and iron ferric carboxy maltose. The efficacy and safety of both of these are great, but the practical problems with the iron sucrose, that at a time you can give only 200 milligram, so the patient has to come back and forth again 5 times at least if she needs 1,000, whereas the whole of the 1,000 you can give it in a bolus dose with the FCM. These are the nuances, but when the situation is such that you may call her month after month after month and give her 200 plus 200 plus 200 and not have the patient missing, yes, you may have. But in the postpartum period also, there is a trend in many institutions. Check the hemoglobin second or third day after delivery, give her the injectable and send her home in the hope that she remains well for a long, long time before her next pregnancy. The efficacy is enormous, and you would see in both the groups, because it just directly gets into the blood and you cannot make any excuses about absorptions, etc. So it is very, very rare not to have an improved hemoglobin of 1 gram per deciliter for every 100 grams of iron sucrose, 100 milligram of iron sucrose that you would give. But if the patient doesn't improve, it alerts you, and you know that there may be something more than iron deficiency, pay attention to folic acid, B12, protein supplements, and the hemoglobin electrophoresis. It may be one odd case of the many that you're dealing with, which needs more correction, and a simple smear will also show if there's sickling and issues like that which need to be tackled in their own merit. So after a lot of struggle with the government, the Anemia Mukta Bharat guidelines in 2018 say that mild anemia to moderate anemia, yes, you are treating them with oral, but closer to term, you need to make sure that you give the injectable so that the meager blood loss should not cost her life. So the severe anemia group, the referrals and the hospitalization and anything that you do should be under supervision, because there are issues with the cardiac system, etc. So the referral networking should be very, very robust. This is an important slide because it's a new thought process that we are parking in everybody's mind. It is that we are always paying attention to correcting the anemia just before she delivers, so that this patient doesn't die because of the blood loss. But pay attention to the neural development and IQ of the little baby, because maximum iron is transferred from the mother to the fetus around 26, 28, 30 weeks. So you have to see to it that her anemia is corrected by then, so that the child gets into a situation of a maximum advantage. This is a new study which we have embarked in many centers, and it is going to be presented to our government in about 18 months from now. And this may well amend the Anemia Mukta Bharat guidelines, that every pregnant woman should have a good hemoglobin at least by the start of a third trimester. So that is what we are battling for, because it's too costly for the next generation to live with these kind of little babies. So the gradation of postpartum anemia, Foxy has declared more than 500 ml of blood loss in a normal delivery. So prevention was the first, early recognition is the second, active management of third stage of labor, which we have instilled to every healthcare provider, and lastly, to pay attention to the original hemoglobin of the patient. If it's already low and she's even losing a little bit lesser than 500, she's still in trouble. So there is a lot happening in the space of managing the postpartum anemia, because the point for discussion is not how to manage the postpartum hemorrhage, but how to manage the postpartum anemia and the fallout of that. So the problem of IDA, especially in the postpartum period, really is another opportunity that we get to make sure that this patient goes home with adequate iron before she's discharged from the institution. So that's becoming a huge target of coverage of the hemoglobin ferritin status for many women who are given this post-delivery. The quality of life, a huge impact, because the decrease in cognitive capacity, as I said, fatigue and dyspnea, reduced productivity. In the garment factories, many young girls who are anemic, they're falling giddy and moving out of the job in half a day, and the